Hello, my name is Jonathan Golledge and I'm a vascular surgical academic in North Queensland, Australia. It's a great privilege to talk to you today about technologies in telehealth for the secondary prevention of diabetes-related foot disease. We're all aiming for happy toes and feet, as you can see in the picture here, and empty waiting rooms. But in reality, that's not what we're seeing. This recent study looks at the amputation rates in a number of major countries throughout the world, both in 1990 and 2017 for women and men. Shown is both the amputation rate for amputations proximal to the toes in purple and amputations within the toes shown in brown. The first thing we can see is that for most countries, the amputation rates have increased over the 1990 to 2017 period. And the amputation rates are particularly high in Australia, as you can see. It shows that there's much more to do in reducing the incidence of complications for diabetes-related foot disease. The burden of diabetes-related foot disease particularly falls on rural, remote and regional populations. This has been found to be the case in many countries in the world, and I give the example here of Australia. Shown is a map of Australia with the relative amputation rates. The highest rate, shown in dark blue, is within the most rural settings, and the amputation rates fall progressively as we move towards the capital cities such as Brisbane, Sydney, Melbourne, and Perth. Another feature of diabetes-related foot disease is that the burden tends to fall more on First Nation populations. In this example, I've looked at the major amputation rates for Aboriginal and Torres Strait Islander people living in North Queensland compared to non-Indigenous Australians within the region. The amputation rates are shown between 2000 and 2015. In the circles are the amputation rates each year for Aboriginal and Torres Strait Islanders living in North Queensland. And you can see that these are consistently higher than they are for non-Indigenous Australians, shown in squares. For both groups, the amputation rates are higher than for Australian averages, shown in triangles. Another important problem with diabetes-related foot disease is its recurrence. Patients are commonly readmitted to hospital with a recurrence of their problem or a new problem, leading to more major complications. This slide illustrates the recurrence of foot ulcers from an American study showing that within 2 years, approximately 50% of patients have a recurrence within the same foot. If we consider the contralateral foot, in addition, the burden is substantial. So what can we do about preventing these recurrent episodes of foot disease, avoiding the important complications and minimizing the amputation rates? Well, the modifiable risk factors for foot disease are well established. They include sensory loss, leading to an insensate foot, and changes in the foot shape, loss of sweating within the foot, all of which leads to high pressures not being felt in the foot and the development of foot ulcers. This, of course, is all driven by ongoing poor control of blood glucose and a range of other medical problems, including dyslipidemia, poor blood pressure control, smoking, and a prothrombotic tendency. So where can technology come in improving the risk factor control for these patients and achieving better outcomes for our patients? Well, there are a whole range of possibilities, some of which are already in common use. They include better ways of offloading pressure within the foot through offloading footwear, improved monitoring of the foot and other medical risk factors, improved ways of accessing healthcare and medical management, for example, via telehealth. Here are some of the examples of this, which I'm going to go into in the following slides. Firstly, we need to think about the evidence base for the treatments we're interested in instigating with technology and telehealth. This is from a meta-analysis that we carried out last year, looking at the data from randomized controlled trials about offloading footwear preventing recurrence of foot ulcers. You can see there are a number of trials which have differing findings in terms of benefit of the offloading footwear being tested compared to the control group. And I'll come back to some of the reasons that might be underlying that. But overall, what this analysis suggests is that offloading footwear can halve the risk of recurrence of foot ulcers. This, along with lots of other data, has led to offloading footwear being strongly recommended in patients who've had a previous foot ulcer in international guidelines. How should this footwear be designed? Well, as I've already mentioned, there's a range of modern ways for this to be done. They include scanning of the foot with a 3D camera and software, as you can see in the example here, measuring plantar pressures during walking with a device within the shoe. This is a PDAR device, barefoot plantar pressure measurement, and using computer-aided software to design the footwear as opposed to the normal handmade design. Currently, we are uncertain which design of footwear is the most effective, and it possibly varies from patient to patient. This is an example of one of the randomized controlled trials testing offloading footwear. It's perhaps the best. It was a very well-designed study by Siko Bas's group. 171 patients with a past history of foot ulcer were randomly allocated to custom-made footwear or usual care. The footwear was designed to reduce plantar pressures by at least 20%. The slide in A region of the slide here shows the main outcome for the study. Disappointingly, the recurrence of foot ulcers was not reduced by the custom-made footwear. One possible reason for this is that the adherence to the footwear was not optimal. Investigators used temperature probes within the custom-made footwear to monitor the use of the footwear and found that the mean percentage steps which the footwear was worn was only 70%. When the investigators looked specifically at the patients who were most adherent to the offloading footwear by using the footwear at least for 80% of the steps they walked, then the results were very different. The bottom figure here illustrates that the recurrence rate for these adherent patients was much lower than for the control group. This emphasizes that to be effective, we need mechanisms to ensure that the footwear is adequately worn. One possible way of doing that is through monitoring adherence to the footwear using the in-shoe probe that I mentioned, that is a temperature probe. And this study looked at that in some detail. 55 patients were randomly allocated to being aware that they had a foot temperature probe in their insole of their custom-made shoes, as opposed to not being aware that the probe was there. And the patients who were aware they were being monitored had a mean use of custom-made footwear that was 1 hour longer than those who were not aware. This supports the fact that monitoring of foot adherence is one possible mechanism of improving the use of foot weight. There are also a range of exciting technologies being developed for assisting patients to avoid high plantar pressures. This includes insoles, which measure plantar pressures and alarm if these are particularly high, smart socks, which also measure plantar pressure. One of these devices was recently tested in a randomized controlled trial of 90 patients with a recent history of a foot ulcer. Here is the insole design, which alerts when a duration of high plantar pressure is seen. And this system was able to effectively reduce recurrence of foot ulcers. Clearly, larger trials in other populations are needed, but this is encouraging results for new technology being applied in secondary prevention. A major other area of research for technology in prevention of foot disease has been foot temperature monitoring. This has been led in particular by David Armstrong, and this was one of the recent studies that David's group performed. 129 patients with a history of foot ulcers were monitored using this podometrics mat, as you can see here. And what David's group found was that this was 100% sensitive, but not very specific at detecting a site which would later go on to develop a foot ulcer. This high temperature site is thought to be the site of inflammation, where high plantar pressures are experienced. And the high temperature, usually identified as a difference between similar regions on the same foot of 2.2 degrees centigrade or higher, had a mean lead time of 36 days before an ulcer developed at that site. So this illustrates that foot temperature is a very real way of detecting a site at risk of developing a foot ulcer, and potentially very helpful for home monitoring. There are a range of techniques that have been used to measure temperature. Here's some examples. This is a TempStat map, and there are a range of infrared devices that the patient can hold. In most of the studies, what has been done is foot temperature is monitored at 6 sites on the foot and compared to 6 similar sites on the opposite foot. And when a raised temperature of 2.2 degrees centigrade or more is detected compared to the opposite similar site, the patient is advised to reduce their activity by at least half for at least 2 days. And if the temperature difference doesn't resolve, to contact a podiatrist. This was one trial, the largest, again by Siko Bus's group, looking at the use of home temperature monitoring as a way to reduce recurrence of foot ulcers. It's recently been published this year. In total, 305 patients were randomly allocated to enhanced care, which involved daily measurement of foot temperature at the sites that I mentioned, and the other group were randomized to usual care without temperature monitoring. As I mentioned, the enhanced care was looking to detect a temperature difference of more than 2.2 degrees centigrade on 2 consecutive days, and patients were then advised to halve their activity and contact a podiatrist. This was the main findings of the study. The primary outcome for the study was an ulcer recurrence at the original ulcer site that the patient had originally developed. And disappointingly, there was no significant difference in outcome, although you can see there was a trend to reduce ulcer incidence in the enhanced therapy group shown in blue. If all ulcers were considered within both groups, then there was a significant benefit of the home temperature monitoring. The blue group here, significantly lower recurrence rate than the red group. There have been a number of other temperature monitoring trials in which daily home temperature monitoring is carried out and advised to reduce activity if a high temperature is detected. And overall, these studies suggest that home foot temperature monitoring can halve the recurrence rate of foot ulcers. Clearly, the results have varied in some more of the recent trials, not as promising as some of the earlier ones. A key question, however, is how this can be brought into practice in routine care. In all of the trials, the patient had to use a handheld infrared monitor to measure temperature at 6 sites in each foot, which is very time consuming, and many patients will not be able to do that. There are these recent developments of the podometrics map that I've already mentioned. This is attached to a very sophisticated telemedicine monitoring team, which is very expensive to run. And therefore, this may not be practical on a widespread basis, although this has been introduced in the US. This cheaper temp map monitor, as you can see, can also detect high temperatures using liquid crystals, although the validity of this in preventing foot ulcers is unclear. There promises to be other devices which are cheaper and widely applicable for using temperature monitoring to prevent foot ulcers, and I think this will be a space that continues to develop. Of course, control of other systemic risk factors, including blood glucose, blood pressure, and lipids, is also key in our patients with foot ulcers. And there is data that if blood glucose is better controlled, if blood pressure is better controlled, and lipids better controlled, that the recurrence of foot disease, in particular amputations, is reduced. There are, of course, now a range of modern technologies for day-to-day or even second-to-second monitoring of these risk factors. Continuous blood glucose monitors are in regular use for patients with type 1 diabetes. There are now watches that have been developed to measure blood pressure with additions for blood glucose. The validity of these watches yet is a little unclear, but I imagine over the next few years, these technologies will come into practice. So what we can see changing now in the management and secondary prevention of foot disease is moving from an in-person hospital or outpatient clinic setting to a remote technology-driven monitoring system in which consults can occur via telehealth informed by remote monitoring of risk factors. Telehealth is in common use now, particularly after the pandemic. But what is the actual evidence that telehealth enhances and reduces the risk of foot disease recurrence? Well, I'm not aware of any randomized controlled trials using telehealth in secondary prevention. There certainly have been trials looking at its use in the treatment of active foot disease, and there have been a number of systematic reviews looking at this. This was one which put together only 2 trials here on the healing rate of ulcers in telehealth intervention group compared to control, and found no difference. So there's more work to do to better understand whether telehealth is a valuable addition. Of course, it's not just the outcome for the patients included in the trial that's important, but the patient's preferences and access to care. There are many other questions to ask about technology in telehealth. They include whether patients are happy to have this technology in telehealth, what health professionals feel, what aspects should be included in a holistic secondary prevention program, and most importantly, what is the effectiveness and cost effectiveness of these type of programs. There is a lot of interest now in co-designing prevention programs in which a research team or health professional group interact with both patients with the disease in question, and here in this case diabetes-related foot disease, and also carers, and also with health professionals to design the program. And we've been looking at this with the idea that we would interact with patients and health professionals to understand the current limitations of secondary prevention, design a prototype program, look at its feasibility, and then go on to test it in a randomized controlled trial. And if effective, see if we can implement that more widely. As a first stage to this, we've currently carried out health professional surveys. This included surveys with 69 podiatrists, 21 vascular surgeons, 16 GPs and 10 nurses. The findings were quite similar to what we thought they might be, and including things like the key deficiencies of secondary prevention, including access and adherence to offloading footwear, and addressing the psychological problems attached to treatment, improved education, and how we can achieve a cost-effective model without burdening the patients with additional costs. So to summarize, there is a huge burden of diabetes-related foot disease, and a key area is improving secondary prevention and improving access to care for Aboriginal and Torres Strait Islander people and rural remote populations. There are a range of options where technology and telehealth can really add to the secondary prevention. These include through monitoring and improving adherence to offloading footwear, designing the footwear itself, achieving better medical management, and improved monitoring of the foot. I do believe that technology and telehealth will play a key role in reducing complications for foot disease, and I think we'll start to see that over the next few years. Thank you very much for this opportunity to talk to you, and I hope it's enthused you about the value of telehealth and technology for preventing foot disease.